Good afternoon. So my name is Miriam Taegtmeyer and I'm starting our presentation on close to community services today. It is a joint presentation and that's on purpose because it's joint leadership, which plays to our strengths and roles. I'm a clinician and my background is in operational research, implementation science, which I came in through my infectious disease background training, working on the decentralisation of HIV services. And I coordinate with the EU, and Sally has a social science and gender equity background, and the joint leadership for us has worked very well in being able to define clear roles and lead different areas. So I'm going to go through the first three questions, and I realise I don't have the pointer. In our overview, which are who are close to community providers and why focus on them? A little bit about what our REACHOUT consortium is, where we're up to and what we've found so far. And then Sally is going to talk about the next steps and some things to look out for in the future and ways of getting involved. I'm going to start with a definition, the working definition that we're using of close to community providers. And just to point out that it's a broad definition. They may be paid, they may be volunteers in this definition. They may be the traditional community health worker, but it may be a less formal provider or an extension worker. There's been a lot of focus on human resources for health and how we reach universal health coverage, and re-looking and revisiting models like community services, close to community services, has received a lot more global attention. Is this one way we can be pushing towards more equitable coverage, towards universal health care? And can we reach underserved areas, underserved people through this? So the human resource crisis has partly been driving this revitalisation, but also a renewed focus on the social determinants of health. And community health systems are that sort of interface between the community and the health system. And community providers are uniquely placed to understand things about social determinants that people in a facility may not be able to see. You know, you go into a house and you see immediately that there's maybe several children, maybe how many wives there might be, whether or not they're using bed nets, what the water supply is like, whether there's an alcohol use problem, and you get that instant interface. Whereas when somebody's got dressed up, walked to a primary health care centre, it's a very different picture that you see, and that is a unique opportunity. But community health workers may not be able to make the most of that opportunity. In fact, there's a lot of expectations on them. They often don't have a lot of education. They may not be well supported. And we may not be able to make the most of that potential. Instead, there's a tendency, I think, of seeing them as the final common pathway of every vertical programme in the world. Oh, we've got an HR crisis, so, we'll get them to collect sputums. Oh, good idea, we'll do a pilot project here. Oh, it works really well for this, let's scale it up. Oh, but we'll get them to do mass drug administration for NTDs, and then while they're at it, they could just distribute bed nets. Do this stuff on, pre-eclampsia. Maybe they could do point-of-care HIV testing. So it becomes like this cadre of people who may have only had a couple of weeks training become that final common pathway. And how do you then retain them, sustain them, motivate them, and get a quality, effective service? Part of the revitalisation has been evidence-driven, and there is evidence on effectiveness. Some of that is low quality, some of it is medium quality. There is some high quality evidence on effectiveness of close to community providers, particularly around neonatal, breastfeeding and child health. But we need to intensify our evidence base. We're still uncertain about how that cuts across contexts. So we have global guidance, but really what does that mean in different contexts? We're still uncertain about what happens over time, because people write up a paper after a one-year follow-up in one little pilot project that is funded by one programme. We're uncertain about how to strengthen and sustain services. What does effectiveness mean in terms of efficiency, and what does it mean in terms of equity, and what does it mean in terms of quality? So how do we define effectiveness? We also have, I'm not sure I want to call it an evidence gap, but there is a sort of gap in the capacity to do good quality research at this level that really involves the voices of communities and the voices of providers. And we don't have much in the way of innovative methods and new ways of doing that. And we need to build the capacity of people that understand local context and are embedded in those communities to really gain the depth and detail of the research that we need. And that is partly what REACHOUT is about. REACHOUT is a consortium. It's funded by the EC. It's a 5-year project. And it has this very strong focus on capacity development for research, but also for organisations, environments, and much broader than thinking about research itself. And our overall aim is to maximise the equity, effectiveness and efficiency of close-to-community services. And we've chosen rural areas and urban slums, focusing on underserved areas in 6 countries: Mozambique, Indonesia, Kenya, Malawi, Bangladesh and Ethiopia. And I think the strength of our consortium really is the partners, as well as the context they represent. All those contexts have large-scale community health programs, have different experiences with them, in them, and all of our partners have worked with close-to-community services, both as implementers and at research level, and work very closely with Ministry of Health in their countries. Some are NGOs, some are universities. Sally is going to tell us a bit more about the different partners later on in the presentation. So if we look at the oval on the right-hand side, that is the aim we were talking about, the overall aim of REACHOUT. And in the arrow on the left-hand side are our objectives around capacity, identifying the influence of context, policy and health systems, developing and assessing interventions, and informing evidence-based, context-appropriate policy making. And we're really doing that in 3 phases. And currently, at about 18 months, we're at the end of the first context analysis phase and entering the beginning of the first quality improvement cycle, which we'll describe a little bit more about these 2. And just to point out that in years 4 and 5, we have a second quality improvement cycle, which will be more embedded and led by service providers and programs. So what have we found so far? Well, we've combined literature review internationally with local country context reviews and multiple perspectives of qualitative research, from policymakers to district people to providers to service users in each context. And I could obviously go on for the entire hour about that. But we created a kind of framework on which to hang our findings around the contextual factors, the health system factors, and the intervention design factors. And both the literature review and the context informed the framework. So there are plenty of frameworks out there. This is a way we've used to organise our thinking around it. And as we did the context analyses, it did evolve slightly. But across the bottom of the framework, you'll see the broad contextual factors, things like community context, the social networks, the cultural practices, the politics. And on the left-hand side, the health system factors, including HRH and policies, service delivery, how it's organised, governance and M&E. Those feed into the design of interventions and both influence policymakers into what goes into an intervention design, where they have to make decisions about HR and quality assurance and M&E. And then what we'll be measuring more of in the next few phases is how changes in intervention design factors can influence provider performance. And you could imagine that through measuring areas at provider level, or some of the mediating processes, or some of the end user endpoints that are brought out in that framework. This slide really just summarises a few of the key bullets that have been emerging from the context analysis. What surprised us is this, on the one hand, context is so important. On the other hand, here are these really different contexts coming up with the same stuff and meeting each other and being like, oh, that's exactly what we're facing. Oh, we could learn from this, we could learn from that. And how certain themes emerge very strongly. And what we're grappling with as researchers now is, what does that mean in terms of a meaningful inter-country analysis, and how do you provide rigorous methods to that? I'm going to stop there and hand over the little microphone to Sally and let her continue.
So thank you very much, Miriam. So we're back to the slide which depicts the overall design of REACHOUT. And as Miriam said, we've finalised our context analysis, and we're now in this exciting stage of just starting our first quality improvement cycle. So the quality improvement cycle is implementation research. How can we make small changes and small adaptations to strengthen close to community provision from different perspectives? And I'm going to take you on this whistle-stop tour across our 6 partner country contexts to tell you a bit more about the partners, what emerged from the context analysis, and in response to that, what is the key focus of the first quality improvement cycle. And the quality improvement cycles cluster either around supervision, referral, or community engagement. So there's similarities there. And during the quality improvement cycle, we will be assessing from a variety of methodological perspectives that impact. We'll then be learning from those, and in collaboration with key partners, implementers, we have this nice opportunity to do a second quality improvement cycle. And we hope, with ultimate aim, that beyond REACHOUT, there'll be further quality improvement cycles as capacity and partnerships are strengthened to improve these services in an ongoing manner. So, take you to Mozambique to begin with. So Mozambique have just evaluated and revitalised their community health worker programme, which they call APAGE. Our partners at the University Eduardo Mondual, Mozambique, Professor Moshin Sidat, has played a key role in that evaluation and in the revitalisation. And they're taking a focus on child health as a key priority within the Mozambican context. And some of the key challenges that have emerged from the context analysis relate to supervision being irregular. When it's happening, it's not supportive. It's more fault-finding rather than supportive problem-solving. Also challenges around resources and monitoring and evaluation, and also referral. So what our Mozambican partners want to do in QI Cycle 1 is to look at structures to support supportive supervision and learning across and between different supervisors. On to Indonesia. So in Indonesia, we're working with the Eichmann Institute in 2 very different island contexts. And a big challenge that's emerged from the context analysis is around communication and developing partnerships between community-based midwives and diverse communities with respect to maternal health. So the Indonesia focus is around maternal health, poor awareness of the benefit of skilled provider and delivery within institutional contexts, despite normal antenatal progress. So looking at opportunities to support communication and to strengthen partnerships between health systems and communities through village midwives. And on to Kenya. Kenya is also in the process of revitalising, changing its community health worker strategy. The current strategy focuses on volunteers. The new strategy will focus on a fewer number of more skilled and remunerated community health extension workers. And the Kenyan Ministry of Health have been learning from Ethiopia, going on study tours there, bringing back ideas from Ethiopia. And so it's very timely, and with our partners LVCT, who are the biggest provider of voluntary counselling and testing throughout Kenya, I think it's a nice opportunity to influence that changing community health approach. And LVCT are the secretariat for the group that is taking forward that process within the ministry. So the focus here is on supporting the revision of the community strategy, how HIV testing and care takes place within that, and the issues that emerged from the context analysis were around quality assurance as well as around supervision. So the focus of QI Cycle 1 in Kenya is around quality assurance. Okay, and on to Malawi. Very pleased to have the DFID advisor from Malawi with us online. So Malawi focusing on maternal and child health. And the work in Malawi is in Chinji and in Salima, and analysing the experiences of health surveillance assistants, a long-established cadre, very much the common endpoint for many programs in Malawi. And the analysis from the context analysis raised challenges around high workload, juggling multiple balls, limited supervision, challenges with referral, and some challenges with coordination with NGO and ministry programs. And like Mozambique, Malawi is focusing in QI Cycle 1 on supervision and on strategies for supportive, empowering, problem-solving supervision and developing a stronger sense of a cadre of health surveillance assistants. Okay, and on to Ethiopia. So Ethiopia, through the Health Extension Programme, has a flagship programme of community health workers called Health Extension Workers, an entirely female cadre working at the local Kabele level. And we're working with HHA, who are based in Owassa. And the focus here is, in REACHOUT, is on maternal health. And like Indonesia, from the context analysis, has emerged a number of challenges around communication, around supportive strategies and links between health systems and communities. So the focus of the QI cycle here is again around strategies to support community engagement and strengthen links between health extension workers and the health development army that in turn support the health extension workers. And our final context, last but not least, is Bangladesh. And here we're working with BRAC University, who have links with BRAC NGO, who themselves employ a whole range of community health workers, Shasta Shabikas, who've had a very clear role in supporting Bangladesh in making good progress towards the MDGs. And the knowledge gaps in Bangladesh, I think, focus around urban slums in particular. Those growing slums in Dhaka and Sylhet, multiplicity of informal providers. So BRAC University are looking at, with a focus on sexual and reproductive health, and in particular on menstrual regulation, so termination of pregnancy up to 12 weeks. So first port of call for many slum dwellers is informal providers, so looking at opportunities to strengthen referral, strengthen coordination and strengthen partnerships between the multiplicity of close to community providers within the slums. So as Miriam said, we've got a very strong focus on capacity building within REACHOUT. That's led by BRAC University. One of the elements within that, which I just wanted to highlight, is SouthSouth technical assistance. So I think we've got strong partners, strong experience of different contexts. So SouthSouth Exchange is a way to support sharing, support experiential learning. So for example, our colleagues from Mozambique have just been in Kenya to learn about LVCT approaches to supervision. There's interest from different partners to learn from BRAC about how they retain and sustain, I think it's 98,000 justice shabikas and those strategies. And so we will be evaluating and learning from that process of South-South exchange. We were all in Mozambique as a consortium for a meeting in March, and our university partners organised for key players in the ministry who are running the community health APAGE programme to come and listen to the different contexts. And there was a lot of interest in what works well in Indonesia and why. So I think this part of our capacity building is about understanding and capturing the strengths of our partnerships, learning across contexts. This table just summarises the key focus of our first QI cycles across the 6-country context. So you can see the focus in terms of child health, maternal health, and then the orange boxes are what will be the main focus of QI cycle 1. So context-specific approaches, but a lot of exciting opportunities for inter-country analysis, for learning across contexts, and also opportunities to bring alive the SouthSouth TA and to learn across and between contexts. Thank you. So we have a strong focus on research uptake, very ably led by Kate Hawkins at Pamoja. And I just wanted to show this slide to see if we can encourage you to partner and engage with us in different activities that we're taking forward in REACHOUT. So we have a thematic working group which is set up, established and endorsed through Health Systems Global on strengthening and supporting the role of community health workers in health systems development. Very strong ownership and support from USAID, from World Vision, from implementing partners, NGOs, researchers. So it's providing an excellent fora to share experiences of what works where, how and why, and how can we learn across. So we've had a number of webinars, we've got events happening at the Cape Town meeting. We have a special issue of the Open Access Human Resources for Health journal call. So the call is out at the moment, papers to be submitted by the end of November. So please do share that with anyone working in this area. And we've come up with 6 key questions to guide papers there, which are really trying to help supplement and support the evidence base around close to community providers. And in turn, each of our partners have set up a strategic consortium advisory group who are helping to design the QI cycles. And it's through those structures we want to really support and embed the processes. So we feel that REACHOUT is feeding into the evidence-based, rigorous research across different country contexts that goes beyond a single health focus and takes a more health systems approach. What more needs to be done? Expanding scope of health economics and costing, and we were part of the group funded by GWA, which in turn was funded through the DFID Policy Research Fund to do work on health economics of community health workers. So that was linking up with our partners in Indonesia, Ethiopia and Kenya. That will be presented in Cape Town at Health Systems Global. Additional equity analysis to look more at coverage, lived experiences of equity, the role of gender, age, disability and the interplay, or an intersectional approach, if you like. How do different axes of vulnerability shape ability to access close to community provider services? And how does gender play out in terms of the experience of being a close to community provider? Learning from best practice, leveraging networks and new partnerships. This is our website. We've got an active Twitter feed and other resources. So please do have a look, and that brings us to the end. Very much looking forward to comments, questions, reflections of how do we take forward these innovative close to community provider programs to support universal health coverage, to address social determinants of health. Thank you.